Right. Welcome, everyone. Welcome to the second session of the 2024 Disability Health Research Center Seminar Series. I'm Bonnie Lynn Sweenor, founder and director of the center. And my visual description is that I am a middle-aged, 40-ish white woman with shoulder-length blonde hair. I am wearing a dark top and dark-rimmed glasses, and I use she, her pronouns. I am really excited for our host today, or our guest today, she could host, Dr. Alison Cernich, who is going to be talking about addressing ableism and advancing accessibility at the National Institutes of Health. But before that, we're going to go through a little bit of housekeeping. Next slide. So we will start with, okay, we're good. Okay, so we will start with some logistics and accessibility and access information. So the session will include a presentation from Dr. Cernich, followed by a bit of discussion between Dr. Cernich and myself, and then we will open it up to Q&A with the audience. We ask that you please use the Q&A function to ask questions. We will receive your messages and then read them to Dr. Cernich. We have CART and an ASL interpreter today. CART services can be accessed through the Zoom link, which has been put in the chat, I believe. And this seminar is being recorded for awareness. If at any time you experience technical difficulties or if you have access needs that aren't being met, please email Mindy at epitts4@jhmi.edu. Next slide. We also want to start with a land acknowledgement. We recognize the enduring presence of more than 7,000 Indigenous people in Baltimore City, including the Piscataway, Lumbee, and Eastern Band of the Cherokee community members. Those are the grounds that Johns Hopkins University is on. Next slide. And if you'd like to learn more about the Johns Hopkins Disability Health Research Center, you can find us at disabilityhealth.jhu.edu. We're on social media, though less so on X these days. And we still plug a podcast, although we haven't recorded in some time, called Included. Next slide. And so with that, I am pleased to welcome Dr. Alison Cernich. Dr. Cernich is the Deputy Director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development, and she works to support the Institute's mission, which is to lead research and training to understand human development, improve reproductive health, and enhance the lives of children and adolescents, and optimize abilities of all. Prior to serving in this role, Dr. Cernich was the director of the National Center for Medical Rehabilitation Research, also in the same institute, and was deputy director of the Defense Centers of Excellence for Psychological Health and Traumatic Brain Injury in the Department of Defense, and has served many roles across the Department of Veterans Affairs. Dr. Cernich holds a doctoral degree in clinical psychology and completed postdoctoral training in cognitive neuroscience. She is a board-certified neuropsychologist, and her work emphasizes has an emphasis on disability in pregnancy, traumatic brain injury, and computerized neuropsychological assessments. Most importantly, Dr. Cernich is an amazing ally for the disability community and has been doing such great work to enhance the inclusion of people with disabilities at the NIH and in research. And I'm really excited to have Dr. Cernich here today. And with that, I'm going to turn it over to you, my friend.
Well, thank you, Bonnie. And I just want to say thank you all first so much for welcoming me here. It's a real honor to be a part of this series. And Bonnie, I just want to thank you and your team for the invitation. Also, just want to say, just to start, that I am, by visual description, a white woman with brown hair that is increasingly gray. I have sort of no glasses or anything. I'm wearing headphones and a blue shirt. And also my pronouns are she, her. So I am going to share my screen. We're going to walk through some slides and then we're going to have some discussion. So let me see if I can make that happen now. Looks like I can. Okay. So slides are good. Everyone on the JHU side, hope so. Okay, great. So we're going to talk a little bit about the work that we're doing at NIH to address ableism and advance accessibility. First I want to say that, most of my work over the course of my career has involved people with disability. I think this report that came out of the National Academies for Science, Engineering, and Medicine is really relevant here. I think that when we exclude people from research, and whether that is people who are pregnant, people who are lactating, people who identify as sex or gender minorities, specific underrepresented groups from racial and ethnic minority categories, people from rural populations, and, particular to what we're talking about here, people with disabilities, what we really lose is the cost of our investment, right? Because what we don't know is how the data that we gather from our research really applies to the population of the United States as a whole. And we know that there is a large population of people with disabilities in this country. And so, I think that we have had at the NIH really more of a disease focus. If you look at the names of our institutes, with the exception of mine and the National Institute on Aging, and potentially General Medical Sciences and the Center for Advancing Translational Science, otherwise, you're talking about organ systems, or you're talking about disease, right? And so really very little of the NIH's funding is not within that context. There's also really no data on the active inclusion of people with disabilities in NIH-funded research. We don't collect those data. So while we do collect data on other aspects of inclusion, this is not something we collect routinely. And so the other thing that we know is we have a number of executive and legislative mandates, meaning things from the White House or from the Congress, that set standards for data collection related to disability, as well as prohibiting discrimination based on disability. And, beyond what we're mandated to do, right? I mean, we really are supposed to support research that is representative of the US population. We also know that healthcare costs for people with disabilities are 4.8 times higher than folks without. We also know that if we do not have the evidence, we really are not providing the evidence for people who provide the resources to address health needs, health disparities, wellness, and reduce inequities. We also know that our data sometimes do not include people, and that affects their ability to really interact meaningfully with the treatments, interventions that we develop, devices we develop. And so, we need to understand the safety, the efficacy, the effectiveness for people with disability. We did a paper a while back from this institute looking at the fact that there are effects of things like, for example, people with spinal cord injuries metabolize medications differently. And if that is the case, then their safety, efficacy, effectiveness can be affected. And honestly, we just can't improve what we do not measure. So next, I'm telling you next slide, and I'm running my slides. I'm hilarious. Okay, so why are disabled people underrepresented in research participation? And I want to make a note, actually, I was talking to Bonnie about this earlier. I am going to interchangeably use disability identity and person-first language, because I know that that is a tension within the community. Please know that I respect either approach to that, but I just want to note that I will be using it interchangeably for people's comfort. So, why is this happening? Well, partially it's ableism, right? So partially it is that, there's this assumption about, either people need to be protected from research because they have a disability, that they are not really able to participate for whatever reason. There's social prejudices. And there are also some assumptions, we can't really improve people's quality of life if they have a disability because they have a disability, which we all know to be patently false. What about the medical model? That's another approach, and I spoke about this with respect to NIH. We really are very much in the medical model, and really this is a focus on illness and disease. So the focus is on the underlying illness and disease that potentially contributes to the disability or leads to disability, not on the person and their health. Cost and complexity. Obviously, if we are including people with disability, we need to do the things that we should to ensure that they are meaningfully included and that they get the accommodations they need to meaningfully participate. And there may be, for some people with disability, the need for proxy consent because of cognitive limitations in function. That said, those cost limitations should not be prohibitive to participation. And finally, and I think, I still hear this and I try to really address it when I can, it's the same for pregnancy or lactation, or for inclusion of children. There's this data assumption, people with disability will introduce things that make our data messy, for example. And I don't think that is necessarily borne out, nor do I think we lack methodology to help address it. And so I think we need to transform participation. There is, for example, and I just have some barriers and enablers here, I'll take quality of life as an example. There is a disability paradox, which is that often people with disability, despite limitations in function, report much higher quality of life than those without. There are lots of theories about why that is, but in scientific fact, that is true. And so, we need to think about, why is it that people don't understand that? How do we educate our culture, our community about people with disabilities? How do we think about a universal design in our facilities, compliance with new rules on accessibility, for example, with medical office equipment and devices? Thinking about how to address that last mile problem in terms of, transportation. How do we simplify consent, the information we have about our studies? How do we make our research more accessible to people? And then thinking about how to work with our primary investigators, our PIs, as I have on here, to really help them understand how to meaningfully include people with disabilities. And what resources they have to start bringing people with disabilities into careers in science to diversify the workforce, right? Those are the sorts of things that we can do to transform this. So I think from my perspective, this is not insurmountable. Now, we're talking about doing these efforts at a very, very large government agency. NIH is about a $48 billion organization. We are the largest funder of biomedical research in the world. And so we really bear a responsibility to think about meaningfully how we are going to transform this. I want to thank Bonnie and Lisa Iazzoni and so many others, including some of our NIH leaders, who really thought through how do we do this better? And so the advisory committee to the director under Dr. Francis Collins provided sort of a roadmap for NIH to address ableism and ensure inclusion of disability, people with disability. And that really relied on a lot of recommendations that came from the subcommittee that Bonnie and Lisa and others led. And they really proposed some galvanizing steps, and that includes updating the NIH mission statement, which I will have a question for the audience later on, establishing an NIH Disability Equity and Access Coordinating Committee, which I'll talk about, thinking about an NIH-wide effort to identify and address structural ableism and promote disability inclusion, thinking about this as a core component of all of our diversity, equity, inclusion, and accessibility efforts, and then maintaining accountability for these efforts. All of these recommendations were then folded into our NIH-wide strategic plan for diversity, equity, inclusion, and accessibility. And anti-ableism is a core component now of those efforts. So, I noted that one of the actions that we were talking about is changing our mission statement. And so our current mission statement is to seek fundamental knowledge about the nature and behavioral of living systems and the application of that knowledge to enhance health, lengthen life, and reduce illness and disability. And in conversations with the community, from one perspective, we can say reduce disability. Does that mean that we are reducing people who identify as disabled and make them less than, right? And so that was a perspective that was offered. And so one of the things that we looked at was how could we convey our goal here, right? What was the goal? So the NIH put forward a revised mission statement, which was to seek fundamental knowledge about the nature and behavior of living systems and to apply that knowledge to optimize health and prevent or reduce illness for all people, right? That went out to the public, and we are now looking at the responses to that request for information. It closed in November. And really, and it's something maybe for discussion later, there is a tension in the community, I think, between folks who recognize optimize health as, take who you are and get you to the healthiest place, whatever that means for you, right? And whether that's developing the best assistive technologies to enable your function, whether that's to reduce your illness, to reduce disability, if that's your desire, right? Whatever that is, that's where we would like to be. There was another group of people in the community who really felt like taking out the word disability took them out of the NIH mission and decreased our prioritization of addressing their disease or condition. And so I think this is where we see a little bit of the tension within the community between the identity community and community that really is person first, that I'm a person, but I have a disability. And some of those individuals would prefer us to leave that in. So I think this is going to be an ongoing conversation. Love to hear thoughts about how to have that conversation in a way that we can learn and potentially modify. And I think this is something that we'll be continuing to work on through this year. I think a huge achievement as a result of the work that was done by a lot of members in the community was that the NIH designated disability as a health disparity population in September of 2023. And I know there are a lot of people here and online who really tirelessly work to educate, to emphasize, to advocate that this is real. And we knew this from the data going back to seminal papers, right, in the 2000s, in the 2010s, really looking at health outcomes, right, for people who often have access to insurance, right, and who also have other social supports. Even with that, things like preventive care are not provided to people with disabilities, right? They have lower vaccination rates, lower regular screenings, higher rates of tobacco use, right? So some of the preventive care even is not being delivered evenly. And so what this designation really does for us is it helps us to encourage research specific to the health issues and unmet health needs of people with disabilities. And so this was a designation decision that is delegated to the director of the National Institute on Minority Health and Health Disparities, Dr. Eliseo Prestable, and his counterpart at AHRQ, Dr. Robert Valdez. And so you can learn more about that on the NIMHD website, but this is really sort of change the game with respect to health disparities research for people with disabilities. As a result, they also launched a funding opportunity, which I noted here, thinking about health and healthcare disparities among persons living with disabilities. And this is really thinking about some of the causes, pathways, and factors that really impact health and well-being for people with disabilities, especially at the intersection of race, ethnicity, and socioeconomic status. Those applications are in, and a number of institutes and centers here at the NIH have signed on to help support this. Another leader in this space, and I have to give great credit to Dr. Teresa Cruz, who's an incredible leader at the National Center for Medical Rehabilitation Research here at the Eunice Kennedy Shriver National Institute of Child Health and Human Development. That's what you see up there, NICHD, NCMRR. They hosted an ableism in medicine and clinical research workshop in April of 2023, so almost a year ago. And really what that did is it really helped us to think about, number one, to raise awareness in our enterprise, and then think about our research opportunities. And I think, bottom line is what we learned is ableism is pervasive. There's a lot of exclusion. And we need to broaden these perspectives, include people with disabilities, and also address ableism as a cause of health disparities, especially attitudinal barriers about the dignity and value of life for people with disabilities. And then this led to a funding opportunity, which has just been, the applications have just been reviewed. And we had really exciting applications there. So we're hoping to make those funding decisions soon. But we really want to understand the impact of ableism and how that affects health disparities and how we can potentially intervene. And I'm just going to note a couple other things. I noted here the strategic plan. We have set up a committee. I have the honor of leading this with fantastic leaders across. Ellen Rolfes is the executive officer at the Genome Institute, and Kevin Williams is our director of Office of Equity, Diversity, and Inclusion. Ellen is a seasoned administrative leader, and Kevin is an equal employment opportunity attorney with a long history of advancing DEIA across federal agencies. What an amazing opportunity for us to work on a steering committee. And what we are doing now is thinking about with a team of folks across the NIH, and this includes people in the administrative, intramural science, and for those of you who apply for grants, that's extramural program. So all aspects of our work, thinking about how we better engage and outreach with disability groups, looking at our policies and procedures for ableist language, thinking about workforce training in all aspects of our mission, looking at our compliance with requirements under the Americans with Disabilities Act and the Rehabilitation Act, really consulting with some of the NIH offices leading some of our accessibility efforts, and that includes our physical plant, as well as some of our IT capabilities. And then thinking about how to build resources for institutes, centers, and offices to promote inclusive practices in their scientific research and their hiring and retention of staff, and whether that's administrative staff, scientific staff, or some of the ways that we develop our workforce externally. We're thinking about all of that. And what we really are trying to get people to understand is there are different models other than the medical. So there's the biopsychosocial ecological model. So thinking about that, the multiple influences that contribute to health, looking at the definitions used for disability in specific programs and initiatives, thinking about how do we address the stigma of reporting or asking people to report if they have a disability. We see a huge gap in reporting if somebody is a scientist with a disability. That's a question that is very often not answered. And we think that is mostly because people do not want to report that because of potential employment impacts. And really thinking also about how we combat discrimination based on disability at organizations who receive our funds. And I have now gotten more use cases for our Office of Extramural Research to consider from a research integrity perspective. Very similar to how we dealt with sexual harassment. The other is that our science can't be inclusive if we don't have scientists who represent our populations. And we know that a lot of folks with disability do not feel welcome or able to access scientific careers. We know that approximately 1.2% of our funded investigators and 3% of our diversity supplement recipients reported disability in our official system. So we want to really think about the barriers here, training, education, and funding, and think about within our policies and programs, ways we can fund accommodations and or supports for disabled people as they write grants and seek support for their science. And think also, we have great representation from our intramural program about how to recruit, retain, and advance the careers of scientists with disability. And finally, I talked about our physical plant, but our Building for All initiative is really thinking about the blueprint of NIH for many, many years to come. And we're also thinking about our materials, how consumable are they, how easy are they to use, and also thinking about the tremendous possibility that we have now with our hybrid formats. How do we extend access? And make sure that all of that is accessible. And I think we still have lots of ways to go, but I think even in the past 2 years, I've seen tremendous gains here. This is a lot of work, and that ends my presentation. But I will say that we have a really engaged community internally that's just beginning. We're starting at culture. So it's starting with just raising awareness in all levels, developing resources that we can disseminate, thinking about our data, and really working on our some of our just basic pieces in facilities, IT, et cetera, because we have to start somewhere. But I think as we start to move, you will start hearing more from us. We're starting our work in places where we can demonstrate and potentially reach things more broadly. So we've picked things like a disability style manual, for example, that all of our policies and procedures, as well as our external facing materials, have to comply with. And that is kind of one of those where once we adopt it, people have to use it. So, thinking through some of these things, it's taking us a little bit to figure out how to move quickly but respectfully. And I'm also really happy to say that over half of our committee has lived experience of disability. And so we really are getting great inputs about what matters and where we need to start. And so I'm just really grateful for this opportunity. And Bonnie, look forward to the conversation.
This is Bonnie. Thank you, Allison. Always so great to have you share about the progress, and thank you for leading that charge. It's I couldn't hear about it enough. It's never thought in a million years. So it's really great, and just so much gratitude. So this seminar series this year is focused on health equity, and certainly a timely topic, I hope. And NIH plays a really important role in supporting research on health equity, as you mentioned in the designation. But can you talk about how the efforts at NIH to address ableism and to promote accessibility in general might be linked to the mission of advancing health equity?
I think it's centrally linked, right? I mean, I think if we are not so from my perspective, if we are not as an organization educated, right? I think it's just like, and I don't think anybody would have said we didn't think racism existed until George Floyd's death, right? I don't think anybody would have said that. That said, sometimes an event has a galvanizing effect. Sometimes a movement has a galvanizing effect, and it transforms not just the way that you think about an issue, but also the way you do business, right? I think that from my perspective, if we don't think about the challenges that people with disability face in accessing healthcare, right, and receiving respectful healthcare that really thinks about their needs and their quality of life and their dignity, and if we don't think about even the way that we design things so that they are accessible, we do a lot on devices, we do a lot on interventions, but if they're only going to reach a proportion of the population, as I said before, then we're not really stewarding our funds in a way that is going to reach all the United States, right? And so, I think that sometimes we just have to push people, just like, we did around race and ethnicity. I think this is a different push. And I think, unfortunately, people understand the race and ethnicity question a lot because it's been higher visibility. I think one of the places in the federal government where this was raised more prominently, everybody remembered during COVID, I think the CDC director made a statement. And it became very clear that value and dignity was not central. And it was very newsworthy, very relevant, very timely. And I think it gave everybody a chance to think, and so I think we need to just keep pressing on that, right? And it also transformed some of our programs when we realized this, right? Some of the COVID tests were not accessible to people, right? Especially people with visual impairment. So we led an accessibility effort to transform some of those tests, right? So once it gets in your head that that's something you have to think about, it becomes something you have to think about. And I think we just have to keep the pressure on for that.
This is funny. Yeah, I couldn't agree more, as I'm sure you would know. Huge fan of the accountability and keeping the pressure on. So related to that, we have a lot of researchers or academics, trainees in the audience. Do you have thoughts or advice of how that group of individuals, those, doing research or in training to do research or doing research, even as trainees, can incorporate efforts to address ableism, better include people with disabilities, and promote accessibility, even when the research isn't focused on a disability issue?
Sure. I mean, I think you approach it like anything else, right? When we think about, it's funny, I never thought about, I'll give you an example outside of disability, right? I never thought about until I was in the position I'm in. So let's all be clear. My background is I'm a clinical neuropsychologist. I worked with people with brain injury, stroke, Parkinson's, MS, et cetera, right? For years and years and years, mental health conditions, often comorbid, right? And so, I always thought about research that was related to them, right? And now I'm in a position, right? I've been a mom, I've been pregnant. I've, had breastfed 2 kids, right? Never even thought about the fact that most of the medications that I could be taking during pregnancy have never been tested on people who are pregnant. Never thought about it. I honestly, never even considered it because I just assumed, right? We make assumptions. And I think when we think about our research, how do we think about our research as a way to be inclusive and to really think about whether it actually really works for everybody, right? If you are doing clinical research in an area that is not disability focused, let's say you're doing it on heart disease, how many people with heart disease do you think may have an impairment in function in some form or fashion? Whether that's a visual impairment, a hearing impairment, right? Mobility impairment, whatever it is, right? You're going to have people potentially in that study who have functional limitations. How are we understanding that, right? Similarly, I mean, I'll give you a great example. This absolutely astounded me. If you look at, we did a Pathways to Prevention effort because I read the physical activity guidelines for the United States. If you've never read them, it's, good beach reading. It's about 300 pages of fabulous government speak. But they're recommendations, right, from the U.S. Physical Activity Guideline Task Force. And I read it because I was on the task force, for sure. And I was reading the sections on disability, and it was all about, well, how do you use physical activity to get rid of your symptoms? How do you use physical activity to improve your mobility or whatever, right? None of it was actually about your cardiovascular health. None of it was actually about diabetes prevention. None of it was actually about anything related to your metabolic health at all. VO2 max, none of it. And I was like, I don't understand, because I know we have exercise protocols for people, right? So we started to look at the literature and what are we doing? So then you look at the literature and you realize that in exercise protocols for people with disability with varying mobility impairments, you know what we never put in the methodology? I'll give you 3 guesses, and you don't need 2. What mobility limitation they have, and if they needed accommodations or assistive technologies. You don't even know that. So how do you generalize those findings if we're not telling people how to make it work? You can't, right? I mean, the fact remains, if we don't represent what we're doing scientifically accurately, right? If we don't think about how we're doing that, then it's really difficult to generalize. Really difficult, right? We have to, we've worked on pregnancy and disability. In some cases, I have to assume that a diagnosis represents a disability. I don't like that, because not everybody who has a diagnosis has a functional limitation, right? So I think as you're researching something, even calling the question, and simply even for your demographics or what you're reporting, if it's not in there, then nobody knows, right? We cannot change what we cannot see. It's just very difficult to do. And so, I think some of those assumptions happen even when you're a person with disability, because you just assume sometimes also that everybody knows that that's real. Just like I assumed that all the medications worked for pregnancy and lactation, and I was wrong. So, you learn these things because you interact with something else and you realize, wow, I just made these assumptions, right? So some of it is just measuring what we need to measure to demonstrate that this population is everywhere.
Yeah, this is Bonnie. This so well put. When I was training in graduate school, I was trained in aging research. And as a person with a visual disability, part of, I think, what led me to pivot to the work I do now was, being in lectures and parts of collaborative research groups and journal clubs. And I always said, well, what about the people with vision impairments? Or what about the older adults? How are you going to modify this intervention for those folks? And it was, always a similar response of, huh.
Never thought of that.
And it just was so profound to me because it's such a prevalent, and that's one small example, right? And it's one type of disability. So yeah, we need more people involved, right? And that leads to the next question is, hopefully, and I think we do have a number of people from the disability community who join these webinars and engage with them. And, do you have thoughts or ideas, or can talk a bit about how people in the disability community who aren't part of the lanes of academia or research, we certainly have disabled people in those areas too, but who are outside those spaces, who want to get involved in research, or ways we can expand research to be more inclusive of the disability community?
Yeah, I mean, number one, I think Bonnie is a great example. This is Alison. That Bonnie's a great example of this. You raise your voice, use your voice. I think Bonnie's used her voice a lot, but I've seen a lot of other people use their voice, right? It's very hard to ask people to advocate, right? But I think sometimes just even thinking about how you increase the understanding of either the challenges you face or even, the fact that, and, I hate to say that this is a surprise to people, that people with disability have good quality of life and are happy functioning members of society, right? Like, not everybody with a disability is, in the stigma sort of world, right? Profoundly disabled and not able to participate, right? And even for people who are profoundly disabled, they participate, and they may participate in their own way. It may not look like how everybody else does it. That's okay, right? I think that that's one piece, right? I think the second is that if you volunteer for a trial, or if you are excluded from something, I think just even raising it with the person, can you give me a reason why? Right? Because the other question there is it you, or is it the way that the process is structured? Right? If your clinic's not accessible and you're doing trials, that's a problem. And if you're receiving federal funding, that's a different problem. So again, when I say there are laws, there are. I mean, that is part of their gig, right? And as we move into the U.S. Access Board put rules out for medical devices and accessibility of medical facilities, and in 10 years, that MRI has to be accessible. It has to have a minimal transfer bed, right? The doctor's office tables are going to have to be hydraulic so that you can get on them no matter where you transfer, right? People are going to have scales that can accommodate wheelchairs, right? That's a rule that we've put in place. There are new civil rights protections around your ability to participate in federally funded programs, right? This stuff's happening. And you don't see it because it's very, like, it's coming. But if you've been in this long enough, which I feel like my gray hairs attest to the fact that I've been in this long enough, you see it move. I was joking with Bonnie before. I have a poster of Judy Heumann. I mean, the basic fights Judy had to have, right, just around her ability to work, her ability to receive education, unacceptable. And we still fight some of those fights, but they're not as hard of a fight as where they were in the independent living community a long, long time ago, right? So I think you keep the push and you say, this is something that I have a right to participate in. And lastly, I will say, don't foreclose participation in a scientific career. And when I say a scientific career, when I think about participation in the sciences, look, I'm not an R01 funded investigator. I sit in an office and opine on things on Zoom, as I'm doing right now. I have a scientific career that looks a little bit different. People in industry have a scientific career that looks a little bit different. People in the venture space have a scientific career that looks a little bit different. People who are in the policy lane have a scientific career that looks a little bit different. You don't have to be in a lab, and you don't have to be in a hospital, and you don't have to be, right? Think about scientific careers a little bit more broadly. Our program officials are amazing scientists, great insights that drive our programs, right? Our scientific review officials have to be able to take scientific knowledge and make it to a place where, we can determine whether or not this is a good idea that we should fund. Those are all scientists, right? And so the other thing I'd encourage people is, don't preclude a scientific career just because you think there's one way to do it. There's not. We think about scientific success, and we're trying to broaden that. And so, I just would hate for people to foreclose on that because they're not in research, right? You don't have to be an R01 funded investigator to be successful.
Yeah, it's the conversation around who gets to be a scientist and call themselves a scientist. It's so important as part of this discussion. So I'm going to turn it to some of the questions, and we've got them piling up for you.
Great.
So I'm going to try to condense some of them. There was a question about, how long are we really going to see change till we really see change in including people with research and research studies, because there's still some gatekeeping. I think you've spoken a bit about that and what we can do in that process and including people. There's also a really great question about clinicians with disabilities and some fear of disclosures. And your thoughts of how that plays into this conversation. We've talked specifically about researchers, and if you have any thoughts or comments about that.
Yeah, I mean, we see it on our data. Look, it's real. And I think people are worried about retaliation, discrimination, lack of access to resources, right? I think that the bottom line is, number one, I don't want anybody to ever do something that's so uncomfortable for them that they feel like they're at risk in some way, right? That's not a safe space, right? But I think that, addressing real risk versus perceived risk is something that we have to think about, right? And so, I think from my perspective, unless we have the data to know, it's really difficult for me to tell you how many people really are investigators here at NIH that have a disability, because we don't have people disclosing because of a fear. I've talked to sponsoring organizations, I've talked to universities, I've talked to publishers, right? And many of them will say there should be no fear, there should be no problem. That said, I've seen retaliation and I've seen discrimination as well, right? And so, if you are experiencing that, let's say you have federal funding and you're experiencing that, you can also raise that to your program official. You can raise that to your grants management specialist, right? At least at NIH, that is part of our research integrity program. If there is active discrimination or harassment, we do not tolerate it, and we will take action at the sponsoring organization level. They've promised you things or they're not delivering. That's something we can do something about, right? But I think the other is there's often also power in numbers. Our employee research group here at NIH is a voice. If you've ever met one of our co-chairs, Kathy Mankepke, God knows, I mean, she uses her voice, and she's an employee here at NICHD. And I absolutely support, I'm executive champion for that group, because I think it's really important that they have a voice and that somebody from leadership listens and brings it back, right? And so find the people that are having some of your struggles, and also find a champion. I think it makes a difference when you have an ally in leadership, because it helps you navigate.
Yeah, this is Bonnie. Yes, I'll just start by saying Kathy is one of the fierce disabled people that JD used to talk about, JD Human used to talk about. Yeah, I think the leadership is key. But yeah, absolutely, power in numbers. So there's a number of questions about how we define disability and who we get to call disabled, and this back and forth and this tension around this. So I wanted to open it for you to share your thoughts, and I know you also might have some questions back for the audience, and I wanted to give you some time and space for that as well.
And I think this is a question that we have been grappling with. How do we define disability? How do we count disability? Such a great question. We have talked about this ad nauseum, I think, and we've struggled with it across a number of different areas, right? I've been around long enough to know that what defines disability probably depends on what program you're in and what you're talking about. Social Security has a definition of disability because they provide a benefit. And so they have to have criteria and ways to assess it, and thinking about the impact of that and preventing waste, fraud, and abuse, et cetera, right? So they have one definition of disability. census has a different definition of disability that, is generally based on function. There are other approaches where it's based on identity. Do you identify as someone with a disability because you have a limitation, right? There are questions as to what constitutes a disability, right? And there are people who ask, does my condition constitute a disability because my environment has to be modified? And I think about this for people with invisible disabilities particularly, right? Where it is a real challenge for them because you can't see it, but it changes their whole world, right? And so, from my perspective, I think sometimes the definition fits the purpose. But in other cases, right, Bonnie and I were talking about this, and this is something I'd pose back, right? We see, even in trying to change our mission statement, that there is a real tension in the community, right? And it's been there a long time. It's not news. This is not news to anybody probably on this call, right? There are people who identify as disabled, who are fiercely identifying as disabled, who see this as part of who they are centrally, and who really feel like it makes really part of them, right? And they see it as, if you're trying to reduce it, you're taking away them. There are others in the disability who don't see their disability as a disability at all. They see it, I think of the deaf community as a culture. And they see it as an environmental problem for you, not for them, right? And then there are folks who would like to not have a disability, right? And that can either be for a person or for a person who may not be able to express this. It may also be for people who are caring for people who have profound functional limitations and need a great deal of assistance and accommodation. And how do we navigate that? It is a public health organization. How do we navigate that conversation? And it's something we're grappling with now. And I think, we have to be really mindful and respectful of all of those perspectives because they're real. Just like a person who is deaf would tell me, I don't need you to reduce this. This is part of who I am. This is really important to me. Versus, I would say, a mother of a child with profound autism may come to us and say, fix this. Right. And that may sound offensive to some people in the community, but that's a real feeling. And so that's, I think, the tension we have to deal with, and how we have that conversation is going to be really important. And I'd love to hear people's thoughts in the chat or Q&A.
Yeah, this is Bonnie. This is, to me, the question I think in general we are grappling with. And, so much of it is about power, and who has the power to make these decisions is part of, I think, the dialogue, as you're describing it. But also, there's a power imbalance within the community about this conversation. It is interesting, and linking it back to data, and there is changing views of disability amongst people with disabilities and amongst society. And there's all sorts of interesting thoughts around how to develop data and data metrics that could also evolve with those views, right? I mean, what we're talking about now might be really different in 5 years. We might be having a different conversation. And it sort of feels like the leading edge of some kind of a change, and that's an uncomfortable place, right? Or that requires uncomfortable conversation. And, I just appreciate you so much because you always are willing to have those conversations. And I think that's exactly what we have to do.
Yeah. I mean, I generally, the way I've always approached this, I see a lot of this in the Q&A, and I'll just say this, the way that so right now it's interesting. I'm restarting my own science. God help us all. And I'm focused on disability. because it's what I've done. And thinking about how we do this, right? We start with, do you have a functional limitation, right? I'm really about often the ICF model, right? Because I think it incorporates not only body, but also environment, right? And sort of that interplay. So I prefer to have the functional conversation, but I'm also a rehab person, so functions in my DNA, right? I get that. But I also think that allowing people to tell you whether or not something is challenging or is not challenging, right? Thinking about whether somebody, I think the other question is, are you disabled? Yes or no, is also a fine question, right? Because that could encapsulate all of it. And so I think we have a measurement issue that we have to solve. I think very much to Bonnie's point. I also think we lack measurement for some really important things for the community, and we have done a terrible job at some of it, right? We don't ask people, what assistive technologies do you use? We don't ask people, how easy was it for you to get them? We don't ask people, how much do you use them, right? And sometimes people are afraid to answer those questions because they worry if they say they don't use them as much, that eventually those will get taken away per policy or program, right? There's a threat in some of this. And I think, what we need to create is a way to get to these measures and ways of thinking about them, embracing a little bit the risks, right? But understanding that if we don't ever measure it, then even, I think about the recent CMS conversations around wheelchairs that, raise people to eye level or allow people to stand, and coverage decision. If we don't study it and we don't provide the evidence, they can't make that decision. Can't, because they don't have the evidence of benefit. And if you don't have the evidence of benefit, you can't cover it, right? So we get in this loop. We have to disrupt that loop somehow. And we have to get over some of the fears. And I understand the fears are real. If you lose your SSDI, that is a real fear. It's also potentially why sometimes they don't participate in research, because the research payment can affect your benefit. How do we fix that? Right? Those are all those downstream questions that if you don't answer, you put people in a really bad spot. Right? And so I think we just have to have the real conversation so that we can fix it from our side too. Right? Because if we don't know what the problems are, we can't fix them. And if we don't have the evidence, we can't provide the service. So that's where that turns.
Yeah, this is Bonnie. So true. That interconnection between data and society, we've got to stay focused on. And I'm going to note that my good friend and colleague Javier Robles put it wisely, as always, in the Q&A. We also have to focus on differences, cultural differences,
Sure.
in the views of disability, and what you just described, and making sure that these conversations and discussions are diverse across the disability community, not just by type of disability, but by other intersecting identities. But you're exactly the things you're saying is to me the next step too.
Yeah, I mean, there are equivalent conversations, right? Even in race and ethnicity. How many languages do we need to translate things into? Right? Well, that's an inclusion question, right? We struggle with this in all aspects of what we do. This is not unique, right? And I do think, I think, Javier, you make a great point about intersectionality. It's funny because at this institute, right, they asked us to do a major, at NIH, we're doing major efforts around race and ethnicity. And our staff said, no, friends, we can't just do race and ethnicity, because I'm not just my race or ethnicity, right? I am my gender. I am my sexual identity. I am my disability identity. I am all the things, right? And so you can't silo me. And I think the more we try to silo, right, and the less we think about a person, and that's how I was trained. I'm a rehab person. I was always told, you look at the whole person. And not only do you look at the person, right, but you look at the person in the context of their environment, because ultimately when you leave that rehab hospital, you got to go back home, I mean, it's one of those, you don't have to go home, but you can't stay here sort of thing. I mean, you could go somewhere else, but I think you have to think about where you're bringing that person, right? And what that means for them. And so I always think about the person and environment, and I always think about the cultural context in which you're doing this, right? Because it is going to vary, and the supports are going to vary. If you experience other discrimination, you're going to have a much harder time. And often people with disability have a lot of intersecting identities that lead to discrimination. And, so they really have sometimes a double, triple, or quadruple whammy. And we have to really acknowledge that for people.
Yeah, well, we are at time, unfortunately, but I think that is a wonderful note to end on. See the whole person for all that they are. Thank you so much, Alison, for being here. This was a great conversation.
Sure.
Thanks for everyone who joined us. Meet us back here next week. We are going to have Dr. Anjali Forber-Pratt, the director of NIDLR, the National Institute on Disability Independent Living and Rehabilitation Research. You won't want to miss it.
No,
Thanks.
you will not. She's incredible.
She sure is. Thanks, everybody.